This episode is brought to you by the American Academy of Orthokeratology and Myopia Control. Go to aaomc.org and join us. Join the war against the myopia epidemic. Welcome to the Corrected View podcast. This is a show about myopia control. It's a show about Ortho-K, and it's also a show about those people who are devoted to its role in specialty care. And we have a very special person with us as our guest today, and that is Dr. Somi Oh. She is a board member of the American Academy of Orthokeratology and Myopia Control. She's a fellow, and she donated to our fundraiser at the lifetime member donation level, which gives her the ability to come on the show and talk about anything that she wants. That was part of the reward for donating at that level. So I said, what do you want to talk about? Somi, welcome back to the program.
Hi everyone. Thank you, Matt, for having this opportunity.
Glad to have you back. We just recorded a podcast with you about your recent article in the AAOMC newsletter. And the topic for this episode is about patients who either have to or want to stop Nightwear Ortho-K. And I thought this was a very interesting topic for us to address because so far in the podcast, we've been, talking a lot about, the emphasis on getting Ortho-K started in your practice for those who are new to it. But I think this is an interesting topic because eventually you are going to run into those patients who either have to or just want to stop wearing Ortho-K. So can you give us a brief summary of why you wanted to discuss this and what we're going to be covering?
Well, as you start providing this orthokeratology therapy to the young people, general, again, and then as they grow and then everything changes, and at some point that their kids are going to come up and say for various reasons, which I will be discussing later, but that I do not want to do this anymore. Then what do we do? So that's kind of definitely seasoned practitioner are going to, if you haven't run into that situation, then you are going to. So past 37 plus years of doing myopia control therapy for thousands of patients, that definitely this is a very important aspect that all the practitioner should be prepared. Then you kind of have to mentally think how can we consult those patients and what kind of a procedure is available at the current time is definitely an important factor. So I think this particular podcast is more for seasoned practitioner, quote unquote, that who's been doing for years, and my hope is to prepare you for that kind of a situation arises in the future.
Gotcha. I mean, from my perspective, I'm not an optometrist. I love working with optometrists, and I talk about Ortho-K sometimes in, pre-COVID, obviously, at a bar, at a party, or whatever the case may be. And people are like, wow, this sounds like the greatest thing ever. So let's go over some of the reasons why Ortho-K why would the patient want to stop wearing these lenses? I mean, for all the benefits that they get, why would this happen? So what are some of the reasons that patients would either have to stop wearing it or would want to stop wearing them?
When I look at the orthokeratology, it ever started out with treating adults first, as you know, that so when adults choose, I kind of look at it visually that adults, I sort of call that as a 25 and older. So anybody who's 25 years old and older coming in and they choose orthokeratology as an option for treatment, to me, that's an adult Ortho-K, which they're choosing an option of either glasses, daily wear contacts, or surgery, or orthokeratology. I mean, that's just one of the options. But when we are choosing Ortho-K for children, that whole scenario, the goal is different. We are doing a myopia control therapy. So I guess in this particular situation, when adults comes in, they want to stop, they simply just drop it and go back to one of those other three options. So this, whatever that I'm going to talk about, doesn't really apply to those cases. But when we run into a child who's still growing and changing and getting worse, and then they've been successfully doing an OrthoK for many years, then suddenly they run into the situation, or you begin to see some problems as a doctor, or the child just, doesn't want to do that anymore. Then how can we handle those situations is pretty much what I'm talking about.
Okay, so let's cover some of those situations. Let's say that the patient is going away to, I've heard this example before, they're going to college, right? And once we deal with the pandemic and college is a thing again that people can go to, so the patient is older now, they've had OrthoK as a kid, and then they're going to go away to college, and they don't want to, I guess, bother with having to, wear the lenses every night. So what do we do in that kind of situation?
So again, that's exactly. So I actually put it here, the reasons for various reasons, but the reasons that children coming up and say, oh, I don't want to do this anymore. It's basically, a lot of times in my case, maybe up to about 15 years ago, who started doing an OrthoK at age 5 or 6, even, then they've been doing just fine for 7 years and 10 years. And actually my son is one of the cases. So I use that as an example a lot to some parents, that it's basically not enough sleeping hours. So then, as a new practitioner, I think when you consult the parents and the kids, that orthokeratology, it's not what I say, it's actually what patients who successfully did OrthoK for 20 years, and that's what they're coming up and telling me, that orthokeratology therapy really helped many children to sort of do a better time management of their daily life. And so again, allocating that 7 to 8 hours of sleeping hours as a 11 years old, 12 years old in junior high school level. And then that continuously, they could do that successfully through the high school. Then those are the ones who will successfully do well until through the college and even up to about 25 years old. So the main reason, the first reason really is the time management failure for teenagers. So not enough sleep hours is one first reasons. And then eventually the second reasons that I've noticed in the past would be some sleep disorders. Teenagers go through, they were fine at 7 or 8 or 9, but suddenly they start getting into the amnesias and some sleeping disorders, and their eyeball length growth, and suddenly they're having a problem with the lid closure issues, and whatever that sleeping disorders happens, then also that could be a hindrance of successful nightwear OrthoK. Then again, for adults, occupational changes and things like that. Even for 19, 20 years old kids, that suddenly the job changes, and a lot of my case, experience that some kids who go to medical school, and suddenly internships and whatever the occupational things that would definitely hinder from, for doing or allocating that 7 to 8 hours of sleeping hours. And then also corneal erosions or frequent corneal injuries, and it's a very small percentage, but again, that could also be the reasons for stopping the nightwear, and also changes of lifestyle and behavior, including nightlife. Again, that happens like in college, or the kid is majoring in architect or arts, and they have to go through many, many days of sleepless nights for midterms and finals and things like that. I think those are the 5 reasons that I've ran into in the past many years of kids coming up with, I don't know, I don't want to do this anymore. So those are 5 main reasons.
I got you. Yeah, there's so many different life events. I remember being in college and staying up and studying and also like partying and having a good time. And
That's right.
so,
Yeah.
like I can identify with that. And also, I mean, obviously the age range of people when they, start a family has changed over the years, but that's also a factor, right? If you have a major life change, like you have a kid, or you, like you said, change in your job, then that all of a sudden then impacts that same routine. So are they like a lost case there? Can we get them back onto OrthoK, or is it better to just switch them into a different treatment plan?
Well, again, so I guess I could sort of give an example of some scenario. Let's say a kid who was already quite highly myopic at age 5, and they started doing beautifully, nightwear. And then suddenly they go high school, like let's say 14, I guess 14 years old. Then boy that start having a girlfriend and start texting until 2 a.m. and they still have to get up at 6, and they're AP students and they're studying a lot. Whatever the reasons, that they're absolutely struggling with allocating that hours. So if that happens, then, and they're only 14, and this child is going to be highly, highly myopic. Once they stop and then we put them in glasses or soft lens, that until about 20 years ago, we really had no choice, but we still need to do some myopia control. So that's where the daily wear myopia control design of RGP comes in. But then very difficult to wear hard lenses as a daily wear for those who are so used to not wearing nothing for years. So, but then now we have a lot more choices. So I guess I could kind of go over those. What kind of options do we have as a doctor?
Yeah, for sure.
Yeah.
What kind of options do we have?
Yeah, because I think last week's podcast I talked about that how do we manage the patients and parents. Then one of the things that I've been using for past 37 years really is when I do the first consultation with the parents and the kid, that it's kind of like, hey, we are not in we are in a long haul. So you are 8 years old, and then myopia continuously progress until about 25. Very speed rate until about 18, more genetically and environmentally affected progression. And then from 18 to 25, it's more environmental factor, like how they study, what kind of reading they do. They're in college and grad school kind of age. So then we already, whenever I present that, I always tell the parents and the kid that you are the player in this game of this myopia control game or play. Then he's the player and I'm the general coach, and the parents are like a home coach. So 3 of us really have to have a right strategy and then deal with. So then according to that particular time of consultation, I do tell them what's available in case of a failure. Because I definitely, as a practitioner, we have to be able to, I always believe that you give a present exactly a realistic picture, not rosy picture only. And then also you have to really under promise and over deliver is kind of the procedure we should. But I really encourage all the practitioners to talk about that next 10, 15 years of consequences. It's very, very important. And again, keep reminding them as they come in for every 6 months visits. So having said that when this happens, then right away I start reminding, okay, you absolutely, I could see that they're sleeping 2 hours, or they're procrastinator of like not to study until the midterm comes and final comes, and they want to, or they fall asleep during studies and whatever that happens, and they absolutely dealing with the fluctuating vision the next day. So, so now we have so many other good options, as you all know. now that we even have a MySight FDA approved as a year 2019 October. And then we have some then we do have a soft orthokeratology lenses been already around for past at least 7 or 8 years, that by utmost, Dr. Arthur Tong's the Endeavor work. Then all the AAMC members should know that it's been already presented 10 plus years ago. So so that's another option. So we basically have to consult the patient and the parents that stopping the nightwear isn't okay, but what do we have as an option for continuous myopia control until they're pretty much into 23 to 25 age. So that's what I guess I like to talk about, what kind of options we have now, which is in a much better place than and how I was dealing with 20 years ago, 30 years ago, that, we had nothing but fitting them with our daily wear hard lens.
Mm-hmm. This podcast is made possible by the American Academy of Orthokeratology and Myopia Control. If you want to learn how to do OrthoK, then we can teach you. If you're looking for a passionate community of like-minded experts, then consider becoming an AAOMC member. Or if myopia management just isn't your thing, that's okay too. Use the AAOMC online doctor search tool to refer your myopia management patients. For more information, visit AAOMC.org and join us. Join the war against the myopia epidemic.
Mm-hmm. So back then you only had the daily wear hard lens, and now you have all of these other options available. I see what you're saying. So when we look, so like, is that how like a practitioner can prepare for this eventuality? Because obviously this is going to happen. So how much should a practitioner prepare for this eventuality? I guess is what I'm saying. That their patients are some of their patients are not going to continue with nightly wear OrthoK. So
as a practitioner start having, large number of patients, especially I'm really more talking about pediatric, the child is doing well, and I hope you're giving a continuously management of this case. And then a child comes up after 10 years of successful nightwear, and then suddenly they start presenting with the problems. Then you just have to go through what's available current time and how good or how prepared I am is what we need to look. And then already in AOMC BVDs that I think I already start giving this kind of a presentation, I don't know, maybe 5-6 years ago already, small sections or whatever. So then that's basically we kind of have to come to the meetings or just various way of dealing with this when the nightwear failure comes and you don't really have any resources, and definitely you could personally contact me or post it in a AOMC forum. Then either way, there seasoned practitioner, we are all dealing with this. Mm-hmm. So not only me, that and
so go ahead.
Yeah.
So there's a general resource out there with the AAOMC membership. So if you're interested in these other treatment options, like you had mentioned, MySight, I want to do a podcast with I've talked about MySight a little bit in the past, but I want to do a podcast about first impressions from different members that have worked with it, and the other different options that we have at our disposal here. Mm-hmm. So one of the other things that you mentioned here on the topic list was the role that keratoconus plays in nightly wear OrthoK, and I was wondering if you go into more detail about that.
Yeah, like keratoconus development. Of course, for the new beginners, if anybody coming in, you already put a diagnosis of a keratoconus. That is always, we tell doctors that it's a contraindication for orthokeratology. But as you all know, that keratoconus a lot of times start developing in the later teens, or it could even to the adulthood. So when the kids coming up with just the general myopia, maybe a little bit more stigmatism. But again, a lot of times they present with normal findings, just a little bit higher stigmatism, and maybe the case start looking a little bit more astigmatic. But so since I've been treating so many thousands of patients in the past 37 years, that where there are a few cases, not a lot, but you are going to run into some conditions where, so then you look back, your 10 years of backtrack it, and everything was actually very within the normal limit kind of findings. But if I just kind of say a few findings would be, let's say, well-going nightwear therapy kids that since age 5, let's say, she was already, let's say, -3 with a 150 still, even at age 5. You know that, and then been controlling really well for 10 years. And then these girls start showing up with when they come in for checks. Then first thing, even though patient already start having a little bit of a complaints, oh, my vision is not right, or it's not, I don't see good as well as before. And then you look at the topography, and definitely you begin to see some irregularity. And then, so you kind of, as if patient wants to continuously stay on that, then sometimes you have to order the child to stop the nightwear in some cases. And those are the things I guess I could talk about in a doctor's side, that when you begin to see some visual acuity correction is not as usual as before, and then the best corrected vision, no matter what you do, that start going worse 2025, 2030. Then also keep giving a residual stigmatism, and topography start looking irregular. The lens stickiness, adherence, and happens more. Then you kind of have to be suspicious that what's going on. But cornea looks great, with the slit lamp exams. So in a case like that, then you have to order to stop, and then having them to stay in glasses. And then you do your analysis. And I guess I ran into a list, I think back, maybe a list, maybe 10 cases, and that I definitely, decided that, oh, this is some keratoconus treatment, is going on. So then you basically, you have to stop the nightwear. And then you just, nowadays we have a cross-linking. It's insurance covers. So then that's one option now. But again, in old days, that you basically, I just take them out of the nightwear and fit them with a daily wear hard lens, keratoconus treatment. So that's kind of that's how we have to deal with. But I guess that's very rare. But then again, you will run into a case like that eventually. But more cases will be normal nightwear failure. So then I guess I could go over those options, I guess. Yeah, but yeah, because you definitely, somehow you really talk to the parents and the child that you really should stop them for going to the OrthoK, daily, regular spherical soft lens. And then that's, to me, that's the most disastrous thing will happen. Then their myopia is going to progress once they stop the nightwear OrthoK. So.
Gotcha. You mentioned cross-linking, and you have a point in here, is when should we refer out for cross-linking? So can you, when is that point? Like, when should you refer out for that?
So now the cross-linking is more researched, and more doctors are learning and doing it. And then you do the research on that, and because as soon as you diagnose of the keratoconus, and then you definitely see that even though the cornea is not scarred, but then you definitely, there's start changing, then I normally refer out to a corneal ophthalmologist to get a second diagnosis. You want to be sure that that's my way. And then immediately, of course, I will, depending on the child, how resistant they are with stopping the nightwear. Then I probably, or they want to, of course, I already stopped. So then how resistant they are to stay in glasses. So until that you really come up with a solid diagnosis. So then I will fit them with, that's where now we have utmost soft OrthoK lens available. It's a month disposable, and keratoconus fitting is the special flex lens is available. So I normally, if they resistant to the wearing of glasses whatsoever, then I normally fit them with a daily soft lens. Then refer out for cross-linking is right away at this point. Because I talked to various cross-linking surgeons, then now they all recommend earlier treatment is better. So before the cornea starts scarring. So that's been my procedure. If the parents and the child is resistant because of this late time and waiting time and blurry vision, whatever, then I will let them, depending on how well tolerating they are, try to fit them with a RGP, keratoconus RGP fitting, daily wear hard lens, or I utilize the soft OrthoK, utmost the soft OrthoK lens, 1 month disposable keratoconus soft lens.
Okay. Is that the most effective soft lens for OrthoK? Is utmost?
Because, well, I know various doctors and people who's been doing multifocal soft lenses. I mean, we've been using, even before my site came out in year 2019, that all the seasoned orthokeratologists agree. We've been using, the multifocal soft lenses as a myopia control lens. We had no other better choice except that. So, ProClear multifocals and try, especially that a high intermediate portion of the high plus has been encouraged, and the AOMC presented, BVD presented so many studies in the past regarding what's the pros and cons and what's better and all. So many studies out there, right? So we've been doing that already. Just that my site sort of I don't particularly, I'm probably one of the first who got certified, but again, we've been using so many other various multifocal lenses as a multifocal, the OrthoK treatment. So I guess, my site is very expensive. So at this point, so that could be a little bit of a problem, but I think I really recommend for beginners, except keratoconus, the beginning doctors, I think we should go to the my site first. That's kind of I encourage, because that you don't have to get a consent form signed and all that, quote unquote crap. So that's the way. But keratoconus is a little different, and then of course that's a long, discussion is needed. But again, among your patients that you took them out of the nightwear, and then you definitely don't want to put back the keratoconus patients as a nightwear, because you're not going to succeed. That it's going to get worse. Visual acuity is going to be worse, and you don't want to mold those keratoconus cornea. So we just have to look for what's available, and then those are at least I use. Try to fit them with the hard lens first. If they fail, then we have the second tool I go to would be the utmost the flex lens, soft OrthoK. And then refer out at their comfort level, refer out for cross-linking. So that's kind of Okay. Hopefully we want to detect that. So don't, So again, this management of the patient comes to how important it is. Even they've been successfully doing 10 years, that they could be developing keratoconus. So we kind of have to watch. I'm actually pretty mean to I don't know, I shouldn't say mean, but my office is very, very good about that, especially myopia control patients, children. If they do not show up in 6 months visit, then my office, we have a certain rules that we follow. My office manager send out the kind of a letter recommending you're breaking the contract we had, that you need to come up, and they various letters goes out. Then they actually miss out for a year. We do send out the nasty letter saying, okay, throw the lens away and go back to your glasses. So,
Okay.
but of course you're welcome to come back. But so yeah, because you're not, I do not want to give a service if you do not come back for the 6 months visit at least.
Right.
For adults, I'm very more lenient, but children patients, because of these things to happen, that so I think I'm more worried about really what if they go away and try to save the main management programs and whatever, and then go away for 2 years, 3 years, and they're growing and changing, and they could really harm them. So that's where that you have to have your office set up for those non-complying patients, and how do we want to handle?
Right. Yeah, that's a great point. Like how you have to come up with a protocol and a plan for every different kind of patient that's going to come into your practice and get involved in a myopia management or myopia control program.
Right.
Yeah, that's awesome. So, what's the age cap for prescribing a myopia control lens? Like, how long is that age group, in your opinion? Like, what's the cutoff?
Yeah, again, my technicians, my techs, they've been so confused and complaining to me. It's like, oh, you have too many variables, and then we don't know what to do and stuff. So I sort of simplified it lately. But again, my goal is always whatever the age that they're studying, of course, studying under 18, under 18 starting point of ortho. I call that a myopia control therapy. But again, if let's say, then 18 to 25, again, I said that still they could get worse. So this is kind of how I cut. Anybody under 18 starting out, first time orthokeratology, I put them in orthokeratology myopia control therapy. Then I do follow up on their axial length every 6 months, and that's myopia control therapy. But let's say then from 8. What about 19 years old person coming in and they want OrthoK? Am I going to sign up as a myopia control? So then that's a question, but at least I do. Again, this is not a prescription. I'm just description. This is a description. In my mind, if it's a new patient and I have no history of his past years, then simply I ask, well, what was your prescription? But again, you look at their prescription and they say it's 2 years old, and then you refract -4, and then 19 years old, and then he walked in with a -4 diopter glasses or soft lens, then you're kind of comfortable. Then I probably will put that person in an adult OrthoK. But if this child is in Berkeley's sophomore and engineering schools and coming in with the glasses -2, and then he says it's a year old and he's 19, and I refract -4, and that could happen. Then what do I do? It's a doctor's discretion. So I am assuming that, oh, you are still getting worse. Then I will put that 19 years old in a myopia control program. So that's basically my guideline.
Okay.
So yeah, until 25.
Until 25.
That's correct. But 18 to 25 is the age where, what kind of a lifestyle they have, their behaviors, study habits, and previous record. You could order for the previous record and see. And by simply taking a case history, you will know. Yeah. So that's
Gotcha.
my guideline.
Gotcha. All right. Well, I think that we've definitely covered the wide range of the topics that you wanted to discuss. Is there anything else, any final notes you wanted to put on it, on this discussion, or is there anything else you wanted to add?
Yeah, I think a few years ago that I did at the VVD, I did a presentation in this how to deal with this nightwear failure. I remember in one of the session that a couple of doctors came up and asked me that what I use as a solution for those cases, and I wanted to do because I was already forming. I formed the consulting forum in Korean ophthalmologists in Korea in year 2018, I believe. So I've been already running a small study forum to help those doctors in Korea. So then I mentioned that, and a couple of doctors came up and said, "Oh, why don't we do that?" So that was sort of left out there for past 3-4 years. Then recently, I think in one of the AOMC forum, that one of the I mentioned about to deal with flex lens and SOK lens. Then a few doctors came up and said, "Oh, I could go ahead and do that study group." So I sort of I own that the procrastination that I am actually just made a Gmail that one of the forum study group. So I'm going to notify anybody who is interested in doing that. Then you could personally email me, because this will be a little specific kind of a study group for this difficult cases to handle, kind of. So I'm going to do that. So my personal email, drsomioh@gmail, DRSOMIOH@gmail. And then of course, we could post those in our AOMC forum, but it's a little bit specific. So whoever is interested in, send me drop a private email. Then I'm going to include you guys in that.
All right. That's awesome. So that's our episode, and Somi, thank you so much for coming on, and thank you so much for everything you've done for the AAOMC. In our online forums that you get as being a standard member, you'll always see Somi's name pop up. She's always helping out, always answering people's questions and lending her expertise. And that just goes to show you, like, the AAOMC is this amazing, we're a nonprofit. We're made up of people just like Somi who are, passionate about the myopia epidemic and helping out and helping to train and educate and mentor other doctors. And this whole podcast is a result of that effort. So if this is something that you like, if this is something you want to see more of, go to aaomc.org and become a member of this organization. And if you have any questions about what Somi talked about or anything that we've talked about on any episode of this podcast, go to thecorrectedview@gmail.com. My name is Matt Herzberg. I forgot to mention that at the beginning of the show. I'm the executive director of the AAOMC, and thank you for joining us for this special episode, and we'll see you at the next one. Somi, thank you again, and I would love to have you back to tackle any other topic that you would love to talk about.
Thank you. This is and please, we really need all you to go out and recruit this anybody with a passion, because I really kind of want to share this, that orthokeratology is not for every doctor. And really, we need to recognize those passion, because passion is equal to love. I mean, I really like to say that the doctor don't have the love for what you do. And then, we are all the spiritual transferring, the human art, you don't have to say anything. You don't have to breathe in and out of OrthoK, but your eye tells everything. That it's amazing that patient sees that. Just that love transfer. So if you do not have that passion and love for doing something about this myopia epidemic, then don't go into orthokeratology. Orthokeratology is a rough road. It's so many variables. I mean, even at this point, treated 3,000 plus, whatever, but I'm still learning every day. Every day there's an obstacle comes in, and I think about, how am I going to handle this? There's always a case comes up like that. So we really want all our members that are recognizing those doctors with that love and passion. And then we really need to build our organization, the AOMC, to the place to go for myopia control. It's really the goal. And I really, really ask you to support the organization. We cannot let this AOMC to go down like what happened with the National Eye Research Foundation. I mean, please. So we really need to help.
Well said. Well said. Somi, thank you so much. I love having you on the show, and I look forward to seeing you again when we can have in-person meetings. Somi's one of my favorite people that I make sure to give a hug to every year at Vision by Design. So
I always enjoy seeing you. Your passion, I see that you really want to help out and work with the organization. You're joyful, and it's wonderful to see you.
All right. Thank you very much. And to all the listeners and audience, we'll see you at the next one.
Bye-bye.
Well, that's it for this episode of The Corrected View. And if you enjoyed this podcast, be sure to thank the standard members of the American Academy of Orthokeratology and Myopia Control, whose annual dues and support make it possible for the AAOMC to put out education, awareness, and content like this. I'd also like to give a special shout out that I'm going to be giving out at the end of every Corrected View episode for 1 full year. And that shout out goes to Dr. Somi Oh for her very generous contribution at the lifetime member level of our fundraiser. Thank you to everyone who contributed and keeping the AAOMC alive. You are awesome.